Hi, everybody. Thank you for joining us for today's webinar. My name is Meredith Gonson, and I'm the 10 Care Lead for the Patient-Centered Medical Home Program. I want to welcome you all to today's webinar on behavioral health for PCMH and distinction in behavioral health integration. Rick Walker, who is the lead coach for Navigant, has put together an insightful webinar today that's going to take a little bit of a closer look into behavioral health for PCMH organizations, as well as walk through some high-level information about the NCQA distinction in behavioral health integration. And we will be posting a recording of this webinar as well as the webinar slides on the PCMH webpage shortly after the presentation is completed today. A few housekeeping items. All lines are muted throughout the webinar. So if you have any questions or any comments, please enter those in the chat box and we'll respond to those. Also, the second portion of the webinar, we're going to have some question and answer time for you all as well, if there are any questions you would like to ask at that time. So I will turn it over to Rick to kick it off.
Thank you, Meredith, and good morning / afternoon to all of you joining us today. I don't know about where you're at, but it's a balmy 56 degrees here in Middle Tennessee, so much welcome, and I hope you have great weather as well. Here's our agenda for today. The entire webinar is based on behavioral health for PCMH, but I've broken it into two sections. The first is specifically related to criteria in the 2017 NCQA PCMH recognition concepts. And then the second half is discussing the distinction in behavioral health integration. And I'm going to take a pause in between the two to break up questions. So if you have questions on the concepts first, we can answer those, and then we'll move into the distinction as well. But if you think of something as we move towards the end, no worries. We will take those questions then. I appreciate it. Just to review some of the concepts that we're covering, here is where these are coming from. And then just some information on the webinar. Again, if you have something you'd like to add, say, question, please enter it into the chat box, and if you address it to everyone, I'll be able to see it, and my host of the presentation, Christina Rodich, will be able to see it as well, and she can remind me if I'm missing anything there also. For some reason, my slides aren't moving like I want them to, but we'll get over there. So our first half, behavioral health for PCMH. And before I jump into the concept and criteria, I wanted to go over some items related to behavioral health conditions throughout our country. You can see, and many of you are aware of this, and so I'm just repeating some statistics, but I think it's really important that we look at these. First of all, the prevalence of mental health disorders. You can see 1 in 4 adults in the United States will experience some form of mental illness or substance misuse or abuse condition. So I don't know what percentage of us on the conference call it is right now, but if, let's say, there's 24 of us, that's a pretty big number. If there's 75 of us, that number even goes up. So think about that. And we are the ones that many times are the first lines of defense for them. It's estimated that 1/2 of lifetime illness begins by age 14, right in the midst of adolescence and going through those teenage years. And for our pediatric and family medicine practices, those are often struggling years for you to get your patients in, because many times their parents don't think that they need anything other than maybe their annual sports physical or something to that effect, and even that's a challenge sometimes. But that's when a lot of this stuff begins, and being able to catch that and get those folks in and being aware of these things are huge, and that's why so many of you are working so hard on your EPSDT visits and outreach within your practices and outreach with the MCOs, trying to get those folks, those parents to bring their kids in. And then I won't go over the other stats there, but you can see those as well. And then bringing it home to Tennessee, 20% of Tennesseans experience mental illness. There's almost 7 million people in the state. I don't do public math because I always do it wrong, but I'll let you figure that out. That's a huge number, and 4.4% of those have serious mental illness. I guess it's good news, but that's about the national average, so we're not out of the ordinary in there, but it'd be fantastic if we were less than that. And you can see some of these other stats, but the bottom one here, the suicide rate, has increased by more than 24% from 99 to 2016. And there's a lot of reasons for that. Of course, I'm sure the opioid epidemic is one of those reasons. But that's staggering, those numbers. And when I was putting the slides together, I didn't think about this as a subset. I wanted to talk about veterans a little bit as well, and being one of them, I think it's important. So many of you are aware that on average, 20 to 22 veterans or active duty military commit suicide every day in the United States. That's about 8,000 deaths by suicide per year by people that have served our country. Many of them have unfortunately seen some things and been involved in some things that are terrible and have changed them in many ways. This is staggering as well. Fort Campbell, which is located in beautiful Clarksville, Tennessee, between 2005 and 2011, there were 85 suicides at Fort Campbell. And then in 2016, there were 156 veteran suicides in the state of Tennessee. So, and I bring these up because it's important to me, but as well, we have a large veteran population in Tennessee. Statistics show anywhere from 450 to 485,000 veterans, both still in serving and those not serving in the state. And this isn't even talking about their family members as well. So you can imagine it's terrible, but you can see, just from our overall statistics for our state and then breaking it down into one subset of it, it is a terrible, terrible thing that we have going on. And we're on the front lines trying to address that. I thought this was important to share as well. This is some feedback from some of our HealthLink providers in regards to primary care and behavioral health. And in no way, shape, or form is this a negative or a slam on PCP. It's just a perspective from the behavioral health side of it. And a lot of it stems from us being busy. It's hard for us to take the time in primary care sometimes to address all those needs or to catch those nuances because we're trying to see all these patients in a 20-minute slot and address not just their one reason they came in, but several reasons. Or in pediatrics, mom, dad brings in one of the kids, but they've got 2 or 3 others, and they start to ask questions about those. So a lot of times we can lose focus when it comes to those. But you can read those there. I'm not going to go into detail on those, but just give you a snapshot of the perspective from some of our HealthLink providers in regards to primary care and behavioral health. Next, here talking about comorbidities and the link between behavioral health and physical health. Many of you that were in our conference back in October, we did a big portion of this, and we had several of our practices talk, but we looked at it as reconnecting the head with the body and putting that whole person back together. And you can see this is a big word, I want to say it. It represents the bidirectionality, I love that, of chronic diseases and mental health disorders. There's a large number of our members who are exposed to many of the risk factors that are noted above in the figure there, and the effect that chronic medical disorders, adverse health behaviors, and outcomes have on them. And a large number of these members present with a low social economic status, maybe in poverty, low educational achievement, or they have insecurity because of their jobs as well and their job status. Some other interesting things where people with mental and substance abuse disorders may die decades earlier than the average person. Some sources estimate as many as 25 years earlier. Crazy stuff. And a lot of it's mostly from untreated and preventable chronic conditions such as hypertension, diabetes, obesity, and cardiovascular disease. And, you know, these conditions get aggravated by poor health habits. For example, inadequate physical activity, poor nutrition, smoking, and of course, substance abuse. So how that affects us, those of you going through the PCMH recognition process or those that have gone through it have been exposed to this. There are core requirements to achieving this recognition and credits based on behavioral health. And here they are. So KM 3, 4, CC 9 and 10, and then TC 8. You can see in there right now that only one of those is a core, but of course, you know, you have to have 25 credits to achieve recognition with NCQA for PCMH, and many of these that you see here are things that you're doing already, so it makes sense for us to look at them and talk about them. So we'll jump into KM 03 here, and we'll talk about depression screening. So basically, incorporating this into your comprehensive medical assessment. Those of you, I would suspect that everybody at this point has been through KM 02 by now. Maybe some of the Wave 2 folks are still working through this and getting it sorted out. But you can see here that you conduct a depression screening for adults and adolescents using a standardized tool. One, for example, many of you use is the PHQ-9. Now, in regards to this standard, the intent is that you as a practice systematically administer depression screening through depression screening tools to the appropriate patient population based on guidelines, and then that you demonstrate a completed screening tool or documentation of the results in the patient medical record. And this will provide evidence of implementation. And what it does is it shows that you're caring for the whole person. And as the medical home, you're recognizing the impact that depression can have on a patient's physical and emotional health. As far as evidence for NCQA, we did talk about an example from a patient record of a completed tool, whether you use that, screenshot of that, show it live during your virtual review. It can be a screenshot of a patient's record showing the results of a screening tool in there. And then you also have to have a documented process of how you conduct depression screening. What I tell my practices and when I try to get all of them to do is if you look at KM 02, which is the conducting a comprehensive health assessment, this is in there. So, and for KM 2 through KM 5, you have to provide a documented process. And my thought is put it all in one document. And then what you can do for the virtual review is if you upload the document, you can upload, create it in Word, put in some arrows that show that you're addressing KM 2, KM 3, KM 4, KM 5, and then save it to PDF and upload it that way for your documented process. And then you can use the same document for KM 2 through 5, and you don't have to create separate ones. What I like about this as well is my goal is with any time one of my practices has to create or revise a document, that they make something that they can utilize in their practice on a daily basis, whether it's for annual training, new hire orientation. For example, with this, you have this documented process. This is how we conduct a comprehensive health assessment in this practice, and you can provide your staff member with that example. So as you can see, here's some examples of these. A standardized tool collects information using current evidence-based approaches that were developed, field tested, and endorsed by national or regional organizations. And in caring for the whole person, you see the impact depression can have on your patient's physical and emotional health. KMO4, behavioral health screening. 1 credit, conducts a behavioral health screening and or assessment using a standardized tool. So, as we saw in the beginning slides, many patients go undiagnosed and untreated for mental health and substance use disorders. Many of them because they're not coming into our practices to see the providers, but many because either they don't share the information or maybe we're not screening for it. So as a medical home, we can play a major role in early identification of these conditions. Practice staff need to get trained on the use of these standardized tools to ensure accurate diagnosis, treatment, and follow-up. And then if you're using reports for any of this, it has to represent at least 75% of the patient population, and that's with any report criteria for PCMH. Many of you, your Medicaid population is that or higher, so many of the documents we're already using have that, but just keep that in mind. You can see you have to implement 2 or more of these. Many of you do more than 2 as it is. Again, in the documented process, state how you conduct behavioral health screening, state what tools you're using, how often they're used, and then for your evidence, again, show a patient completed form by a patient or somewhere in the patient's medical record where this information is documented. And the nice thing about this is that the information is shareable across all sites. So you have your documented process and you only have to show 1 patient example. And this is worth 1 credit as well. CC09, this is in regards to behavioral health referrals. So you work with behavioral health care providers to whom you frequently refer, and you have a set of expectations for information and patient sharing. But one of the things is you need to ensure that you have a documented process and that it outlines the established expectations for the exchange of information. For example, frequency, timeliness, content, and the NCQA reviewers will look for that. They'll look for that in your documented process, and they will look for it in your evidence as well. But this is one area where maybe you have some type of mutual agreement with a practice, some other practice that you have. Just need to see a relationship between your primary care practice and the behavioral health care specialist that you're referring to. What kind of relationships have you established? Any notification demonstrating inability to receive a report, things of that nature. If you've had issues with someone, maybe you could show something to that effect. I mean, that's probably not the best thing to show, but it does show that you're monitoring and tracking that. You may have an agreement that you can share. Some of you have formal agreements. Others have informal agreements. Some of you have your own behavioral health staff in-house. Others have other behavioral health organizations with staff members embedded in your organizations. Whatever it is, your documented process needs to outline that and then show the evidence of that implementation. Or if you have an agreement, that's just as good. You can show that because all those things will be identified in that agreement. And this could be an example of a documented process even laid out, just something that you can utilize. And it's really an essential function for any healthcare agency. You don't necessarily have to be the one providing the behavioral health care or treatment, but we need to have some process in place that our patients can get the things that they need. And then making sure our staff is trained to do these things and to identify these things. And then again, on agreements, formal or informal. Many of you have shared patients and trying to identify those. I know it's a challenge. I get it. But trying to identify those and make sure that we are not stepping on each other's toes in regards to treatment, and that we're working together to make sure that our patients, our clients, are being served and have the tools necessary to overcome these things and to get past this. Again, it's time intensive. There's no doubt about it, and those of you that have done it know this. But again, determine which healthcare providers, behavioral healthcare providers you have relationships with or are in your community, or maybe some of your colleagues have relationships, and get with them. PCMH, Behavioral Healthcare Manager, has at least one care manager qualified to identify and coordinate behavioral health needs. And I won't read all that stuff to you there. You can see that. This is one item that NCQA changed the language for as far as the guidance in the standards. Initially, it was the language said something about to provide treatment for, and that was going to be an issue for a lot of practices, especially small practices that didn't have any type of behavioral health care providers within their organizations. And they went back and they changed the terminology as they did the updates. But you have to identify someone as a healthcare manager that is coordinating the care or overseeing it. They don't have to provide it. So the common question is, how do I know who's qualified? Well, the nice thing is you get to determine what the qualifications are. And this is quite a broad spectrum. I have one practice, for example, they really are engaged with BHIP, behavioral health in pediatrics, and trying to manage as much of the behavioral health diagnoses and issues as is applicable and appropriate for them. And they actually have an MA who oversees the coordination of that care and the referrals and things of that nature and tracks those. They're not providing the care, but they are making sure that those that have been identified to have some type of care management or need more than what the practice can provide is keeping an eye and monitoring those things. It can be from that position to having an LCSW on staff, or in-house that is from another organization who manages that. It can be one of your providers that manage it. It could be a provider team. Maybe the team manages their own behavioral health, their patients with behavioral health needs and concerns. So it's really, again, it's up to you how you do that. You just have to provide evidence that you've identified a behavioral health care manager, and I would give a brief outline of what their role is. Number one, I would have that documented so the person in that position knows what's expected of them and what they're supposed to do, and then you can provide that as evidence as well to meet this criteria. So that was worth 2 credits, and then this one here is worth 2 credits as well. And this is going to lead us into our next section here, but this is where we get into the behavioral healthcare integration. So CC10 integrates behavioral healthcare providers into the care delivery system of the practice site. And you can see there's 3 ways that you can do that are identified here. The more involved, the integrated portion of it specifically is more involved than the other 2 can be. But it's just, you've got to determine what is best for your organization. Is it realistic to hire someone that you can have on staff to take care of these needs? If not, Is it realistic you can work out some kind of co-location agreement with another practice, a behavioral health practice, where they have a staff member come on site 1 day, 2 days? I know some practices that have a staff member from another organization on site 5 days a week. The patients don't know that they work for another organization. It's just a part of their doctor's office. And as many of you are aware that have done integrated care, especially in behavioral health, the outcomes are phenomenal. It's just amazing how many more patients take it seriously, come to their appointments. There's this block about going to the mental health clinic. People don't want to be seen going in the door. They don't want to be seen driving up there sometimes. These are all concerns and issues we put on ourselves. But think about it, working in a primary care setting, the patient's just going to their doctor's office. In my last assignment in the Air Force, we were one of 3 outpatient clinics that did a pilot on integrating behavioral health into our family practice office. And it got to the point where we had 2 full-time behavioral health providers, an RN, behavioral health RN, and one of our mental health technicians down in the family practice clinic full-time. They were in there full-time. They were busy from 7:30 to 4:30. Patients came in. They liked it. There was a stigma that was alleviated in many cases because you weren't sitting in the mental health clinic lobby. You were in family practice. You were there to be seen by your provider. And it made it a lot easier. And for many of you that have patients that struggle with transportation issues or getting to appointments, if you do integrate into your primary care sites, the opportunity to lower your no-show rate and improve your kept appointments is huge. Now, what you need to do for this is to provide a documented process, how you do it, and evidence of implementation. A documented process just lays out how you do this, whether it's coordinated care, whether you're referring out, whether you have some co-location agreement, or you have integrated healthcare within your organization. And then evidence of implementation. Could be a contract, could be some other way that you're showing how you have these providers, how you're integrating your care. Here's sort of a snapshot of what this would look like having this in your facility. And then a couple of statistics I looked up, got these off the Behavioral Health Barometer for Tennessee 2015. 2 stats here. Children and adolescents younger than 17 years of age reported an improvement of a 71% improved functioning from treatment received in the public mental health system. 71% reported improved functioning. And then for adults 18 years and older, it was 66%, just by getting their mental health needs addressed and taken care of. I know you know that. I know you know when we get these things done and seen, it makes a big difference. But it is a struggle sometimes to get these folks in here. So again, if you were at our conference in October, you saw this slide where connecting the head back to the body. So, what is the definition of integrated behavioral health? It's care that results from a practice team of primary care and behavioral health clinicians working together with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. That was awesome, wasn't it? It's pretty good, but it's addressing our head and our body, because we know that if our emotional state, our mental health state is off, a lot of times our physical state will be off, and vice versa. You know, and we can also address substance abuse use and the health behaviors that go with this. And many of those are just contributing to chronic medical illness and the life stressors that arise from that and the stress that's put on the body because of those things. So the collaboration of the two provides complete treatment to the patients, and then hopefully, and I know it's true because I've seen it in many patients, and you have as well, you get overall improved well-being. Let's face it, you know, many of us have been through struggles. Life happens. We've maybe had some type of stressor in our lives. We've lost a loved one, a job, things of those natures. And you know that when you're low emotionally and mentally, it's hard to do the physical as well. Or if you're chronic pain, look at the issues we have with chronic pain, trying to get that under control. And how many, you know, we address it through medications a lot of times, but how much of that is in our emotional state, our mental state as well. And I know that we are seeing a lot of ideas for using imagery and self-talk and things of that nature to help in overcoming chronic pain. I thought this was pretty incredible. Less than 50% of medical students are exposed to integrated behavioral health in a primary care setting. That's not good. That is not good at all. But I do want to recognize ETSU up in Johnson City. If you were in the conference in October on the East, you heard there that they are, with their medical students, exposing them to behavioral health in the primary care setting. So thank you for doing that, ETSU. And I'm sure there's a couple other U's that are, but I know specifically that they are, and that's huge. They have to be exposed to this. And why is it important? Who benefits? Everybody does. Patients, caregivers, you as providers, and then the larger healthcare system. And as you know, coordinated care reduces the depressive symptoms. It enhances access to other services, especially when you have someone like a care manager or a care coordinator helping you to make this all connect instead of having to try to do it on your own. You imagine you're struggling mentally and emotionally or physically. You just don't have the time or sometimes the gumption to even do these things. But if someone's taking care of that for you, your chances of getting the care you need improve dramatically. And again, it improves quality care and then lowers overall health. So what's the importance of meeting these behavioral health related criteria? Well, not just, well, one of them is if you don't meet them, especially KM3, you won't earn your NCQA PCMH recognition. That's not the most important, but that is one of them. But if the behavioral health problems aren't identified, not treated, it's be challenging to get our patients physically where they need to be. If we don't integrate, it's possible to improve outcomes both physically and behaviorally. And then hopefully, you know, we're hitting that triple aim as well, improved outcomes, improved satisfaction both from the patient's perspective and the primary care provider, and reducing cost of overall health care. So with that, I'm going to stop there and see if there are any questions on the concepts for PCMH related to behavioral health thus far. So if you have a question, please enter it in the chat. Make sure the send to says to everyone. If it says to host, that's all right. It'll go to Christina and she'll relay the message to me. Or if you have a novel idea or something that best practice, that'd be great if you could share that with us at this time as well. So I'm going to go silent for just a moment and see what we've got question-wise. All right, one question is going back to your to TCO8, behavioral healthcare manager. Again, who can that be? It's a staff member that you identify, that you determine what their qualifications are and what they're going to do, whether it's a provider that's going to oversee this overall coordination, whether it's a team, whether it's an individual. You determine as a practice who it is or who they are and how it's going to work, and then roll it out and go from there. And I'm sure that person will learn along the way, but make sure that you identify what their role is and what the requirements for them are. And then if you can, get them some additional training if they need it, for example. All right, and with that, I will move on into the PCMH distinction in behavioral health, and Meredith's going to join me for this one. So I'm going to reintroduce Meredith to this, and we're going to discuss this together. Welcome back, Meredith.
Thanks, Rick. So I'm actually really excited about this portion of the webinar because the PCMH distinction and behavioral health integration is something that I'm learning more about. And I know several of you on the call are kind of curious as to what this is, this new distinction through NCQA. So I'm really excited to kind of share more information about this and also just pick your brain, Rick. I have some questions for you, and I'm sure several people will probably chime in chat box with questions as we walk through this. But just really wanted to kind of get a better understanding of this distinction. So the first question is, what exactly is the PCMH distinction in behavioral health integration? What is this recognition?
Well, that is a very good question, and probably the first on everybody's mind. But really what it does is it's a behavioral health. The integration model calls for a care team in primary care that can manage the broad needs of patients with behavioral health-related conditions. So the expectation is integration of behavioral health expertise, including staff, to enhance the care provided in the primary care setting and to improve access, clinical outcomes, and to recognize and improve patient satisfaction. The one thing it does, in particular for the practices, is it recognizes PCPs that are putting the right resources, evidence-based protocols, standardized tools, all these things in place, recognizes them for meeting the behavioral health needs related to these conditions that they found through the primary care setting. Excuse me. It enhances the level of care provided in a PCP, which improves access, clinical outcomes, and the patient experience for patients with behavioral health needs. And it's a way for practices to highlight where they excel beyond the regular PCMH standards.
Thanks, Rick. That's very helpful and gives me further clarification about what this distinction entails. So as we're thinking about this, what type of practices would be eligible for this recognition?
Another good question. So practices that are currently in the process of earning NCQA PCMH recognition are eligible for that. And many of you, as you've been enrolled in QPAS, have seen whether or not you wanted to enter into this. And then practices that have already earned NCQA PCMH recognition and are seeking some other distinction during their annual reporting can apply for this as well. And if the distinction is completed during the initial PCMH recognition process, there's no additional charge for the practices.
Okay, that's helpful to know, Rick. So what exactly are the requirements for a practice to achieve this distinction? What does it take?
Well, the nice thing is it takes a little more than half the work you're already doing to kind of get there. So there are 18 criteria across 4 different competencies in this module, and you have to meet all 11 core criteria and then 2 elective criteria. And I'm going to get into these a little bit in the end. But the nice thing is that as you go through and earn the PCMH recognition, you complete 7 of the core criteria that are already included in there. So more than half your work is already done. You've just got 4 more core criteria and 2 credits that you have to look at earning.
Oh, that's great. That's a good feature there. So I know you mentioned that practices can work towards this distinction as they're doing their PCMH recognition, and that if they do that, there are no additional fees. But what if they decide to work towards this distinction after they've achieved NCQA recognition for their PCMH recognition status? How does that pricing work?
Sure. Again, you can see the second bullet there talks about that if it's outside of the initial or the annual reporting fee. And really, this right here, when you get the slides, everybody, you can go on there and it takes you to NCQA's website and it'll give it more to you. It's similar to how PCMH is based on the number of providers you have and the number of sites. So without going into too much detail and muddling it up, I'll divert to NCQA and their information there. The one thing I do want to add as well is that this distinction is an annual renewal as well, similar to the PCMH recognition. So once you earn the distinction, then you can, if you want to maintain it, then you just could do that annually with your PCMH recognition.
Okay, thanks, Rick. That's helpful to know and to be able to click on that link. I think it would also be helpful if an organization is going through the recognition process or thinking about this before they enroll a site. And just working with the Navigant coaches as well as their NCQA representatives to figure out what the best plan and strategy would be to approach this distinction recognition. So this is very helpful, and I appreciate the hyperlink.
Awesome.
All right. So what's the why? What are the benefits of earning this distinction? Why should an organization even pursue this?
Again, good question, and there's several reasons, and here they are here in an outline. But number one is if you're doing the work, you might as well get recognized for it, right? If you're doing it, take credit for it. But you stand out. You demonstrate to your patients, to payers, and any partners that you have that your practice has the right resources, protocols, tools, quality measures in place in your primary care setting to support the needs of your patients. Improved outcomes. Distinction results in an enhanced level of care and improved access, clinical outcomes, and the patient experience. And then you're delivering whole person care. It helps practices to provide comprehensive care that acknowledges patients' behavioral needs beyond the core requirements of the NCQA PCMH recognition. And I would like to point out that 2 of our PCMH practices in Wave 1 have already earned this distinction. Primary Care and Hope Clinic in Murfreesboro has earned it, and ETSU Pediatrics in Johnson City has earned it as well. And there are a number of others that have enrolled in it are going through as part of their PCMH recognition. So congratulations to you 2 for leading the way.
Ditto. Kudos to those 2 providers for achieving this distinction. And also, thank you, Rick, for letting us know why this distinction would be important and how it would help a practice to stand out. So I know you slightly touched on the requirements for this recognition, but could you go a little bit more into detail about each of the requirements and the areas that they cover?
Sure. Again, this is Appendix 4 in your 2017 NCQA PCMH standards. Make sure you have the right edition, the 2017 edition, version 3, and you can see that's at the bottom of the slide. But you have that zip folder dated, I believe it's dated July 24th, there it is, yep, 2018, then you have this information that I'm going to go over in your in your documentation. Again, 7 of the 11 core requirements are earned through the recognition of PCMH. There's 4 competencies, and again, you've got to meet, in this regard, you have to meet all the core requirements, just like PCMH, and then 2 elective criteria. So here are the 4 competencies that are covered throughout these modules, and I'm going to go over each one of them slightly and show you where the, going backwards for some reason, here we go, and show you what is in there. So competency A, behavioral health workforce. So practice incorporates behavioral health providers at the site, utilizes behavioral health providers outside the practice, and trains your care team to address these needs. So there's 6 criteria here, and there's 4 core total and 2 credits, but you receive 2 of the cores as you go through the PCMH modules. So BH01 is equivalent to TC08, which we talked about, identifying your care manager, and then BH05, behavioral health referral expectations, is met through meeting CC09. So actually CC09 is a credit. They're both credits actually in PCMH, but you earn core criteria for the distinction, which leaves 2 more core that you have to earn in this section and 1 of the 2 credits. Competency B, information sharing. So the practice shares patient information within and outside the practice to support integrated and coordinated patient care treatment plans. So there's 1 core and 3 credits in this section. You do earn BH1 is equal to KM18, which is reviews controlled substance database when prescribing relevant medications. So again, that's a credit. If you're earning that credit in your PCMH recognition, you're earning that here for the distinction in behavioral health. Again, taking credit for things that you're already doing. Competency C, evidence-based care. So you use evidence-based care protocols to identify and address behavioral health care needs. And there's 4 core and 0 credits here, but you receive all 4 core requirements by meeting KM03, KM04, KM20A, and KM20B in the PCMH manual. So 1 competency is totally accomplished in this distinction by just what you've done in the PCMH recognition. And KM3 and KM20 are both cores, and KM4 is a credit, which again you're doing, so take credit for the work you're doing. And then competency D, measuring and monitoring. There are 2 core and 2 credits here. Unfortunately, you don't get any credit from the PCMH module, but think of this module as equivalent to the QI module in the PCMH recognition. So for 15, BH15, it's monitor and adjust. So you're looking at mental health or monitor and adjust mental health or substance use disorders. So you're looking at symptoms over time, and you're identifying mental health or substance use conditions and adjusting treatment plans for those patients who don't demonstrate improvement. 16 is an elective that you monitor and assess for both a mental health condition and a substance use disorder. BH17 monitors performance using at least 2 behavioral health clinical quality measures, and BH18 is sets goals and act to improve upon at least 2 behavioral health clinical quality measures. So sort of like doing QI 1 and QI 8 or QI 4, and I think it's QI 11. Can't remember off the top of my head. Very similar. So as far as additional work, there's a little bit of additional work to earn this distinction, But again, you've earned more than 50% of the core criteria for this. And if you're providing some type of coordinated or integrated behavioral health care, more than likely you're already doing all of these things, and you can take advantage of achieving that recognition. Here are some resources. The first one relates back to NCQA's website for it, and then there's some other links that we thought would be beneficial for you in determining whether or not to move forward with this recognition. And again, you don't have to do it necessarily at this time. If it makes sense to do it at this time, get with your coach if you haven't already, and we are more than glad to help you work through this, and then go for it and do it. Again, taking credit for what you're doing, or maybe it's time to challenge yourself and step up to that next level and implement something new. And you can take advantage of all those amazing quality improvement resources that we have provided to you through the last 2 years in our conferences and collaboratives. And if you're missing some of that information, please reach out to us and we will provide that to you. So with that, brings me to the conclusion of that section. First, Meredith, any other questions from you I may be able to answer?
No, this was very helpful and insightful. We'll just throw it over to people on the line if they have any questions or comments or thoughts about all of that information.
All right. Yeah, if you have any comments, questions, best practices, novel ideas, please share those with us. We'd love to hear from you. And, if you ask us a question that we can't answer at this time, we will find out what the answer is and get back to you.
I wonder if we have anyone on the line from Primary Care and Hope Clinic or Newport Youth who could speak to their experience walking through this distinction. Maybe they could put some things in the chat box. I'm not sure if they're on the line, but if you are, we would love to hear from you.
All right. Well, I guess one of the questions I get asked is this worth taking the time to do? And I'm sure if we had ETSU or Primary Care and Hope on there, they'd say yes, it is. If you asked the patients, they'd say yes, it is. And again, going back to what are the benefits for you as a practice doing this is you stand out, you should have improved outcomes, and ultimately, the ultimate goal is seeing our patients be the best they can be, regardless of what their condition or situation is. Will they ever be 100%? I don't know. Many of us, at this stage in my life, I've got aches and pains and issues that will probably never go away, but I know how to deal with them and treat them, and I found ways to work through those. And a lot of that is, I've done on my own, but as well as from my provider staff and the folks I've worked with, and being in healthcare too. I mean, that definitely helps. So that's really the biggest outcome of it, I think. And again, if you're doing the work, then man, get recognized for it and take credit for it.
Rick, we have one question.
Sure.
Is there any additional funding available through the incentive program if the additional distinction is achieved?
The only way that you would get additional funding is your quality improves. So obviously the outcome payments are geared towards high performance in those areas of quality. So that would be a way to kind of drive your incentive payment. But there are no specific incentive payments designated for obtaining this specific distinction.
that puts us pretty close to time. I do appreciate you taking your time to spend with us this morning, this afternoon. I hope it was beneficial and helpful. Again, if you have any questions, reach out to your coach or myself or TennCare or to your MCO representatives. We're here to support you in every way possible as you support your patients and our fellow Tennesseans. So with that, I will return control to Meredith as we wrap up. I wish you all a great day, and we'll see you soon. And Merry Christmas and Happy New Year.
Thanks, Rick. And thank you for this webinar. This has been very insightful and informative. And if you all have any questions or comments that come to mind after today's webinar, please feel free to reach out to Rick or your Navigant coaches or myself, and we'd be gladly to circle back with you all about that. I do want to give you a save the date. So our next PCMH webinar is going to be on documented processes and evidence. And so Rick is going to be hosting that webinar January 30th. It's currently set for this same time frame, 11 to 12 Central Time. So we'll be sending out a calendar invite and just more information about that soon. But just wanted to put that on your radar to save the date for the next webinar session. And also just a reminder that we're going to be posting the recording of this webinar as well as the slides on our PCMH website. So if you have staff members who weren't able to attend or you just wanted to revisit the materials, it'll be there for your reference. And so we'll also let you all know when those are live on the website. And so I just thank you all for joining us today for the webinar, and I hope you all have a great weekend.